We're now moving on to the next on swallowing and airway. I invite Professor Dr. SURESH KUMAR. He's the director in charge of UIORL Madras Medical College. And Professor SURESH KUMAR is an all-round head and neck and ENT surgeon and a great teacher. We also have Dr. Vidyadharan Shivakumar. He is a young, dynamic, and always smiling head and neck ENT surgeon from Thank Hospital, Chennai. He has multiple international fellowships and trainings to his credit. Dr. Nilanjan Baumik. Okay, first we'll have the talk by Dr. Suresh.
I sincerely thank Thiru for giving me this opportunity. Good morning, Thiru. Thank you very much for giving me this opportunity. Right, wonderful conference that you are having, and I also thank the organizers here as well as the administrators of this prestigious institution like Kamakoti Hospital. This is there for ages. Like even when I was a child, I know about this hospital. So what is this particular swallow doing here in the midst of this airway group? That is what is all the uniqueness of what a swallow is all about. So just I wanted to impress upon this audience that I am not a swallow surgeon or a swallow physician, whatever it is. I do less work there except for removing a foreign body from the esophagus, but I am very much passionate about swallow deglutition. And people used to say, like in the lighter vein, I'm just saying, those guys who are a bit fat, they say they eat more. No, it is like not that way. It is more stressed out, they say, of not getting good food, right? So in the later vein, we'll start about this particular topic, swallow. Most of these slides which I have prepared is my understanding of this swallow, and I have not got any videography of or video fluoroscopy, all these things which I have not really have an access on. But only thing is, as a very primitive person involved in swallow, I just try to make all of us here know certain facts which I know. That's it. So from the introduction point of view, these humans, they are initially the hunter-gatherers, right? So in the Ice Age. So what they literally did was nothing to do with a very civilized swallow that we have now gone in. So as the civilization went on from the Ice Age to a particular civilized period, we developed tools, we developed agriculture, and from the agriculture we started having or taking food. Food is really like probably the soups and the beers and the breads, all these things. And then once that has started, we started to have food in all the occasions, like whether it is a good occasion or a sorrowful occasion, we have food. So taking food is one of the most important part of a culture that we have developed all these years. So with that, this is a very complex coordinated reflex action, which is usually initiated voluntarily, but most part it is completed as an orderly sequence involuntarily as a reflex. So the Scott Brown in 4th edition used to tell that this is a very well coordinated action, but then when there is an action that is happening, we always have some subsidiary actions that has been there. So we use the swallow even for the swallowing of the mucus from the nasal passages, also from the trachea or laryngotracheal region where we have to get it out, and then again we have to swallow. Along with that, very important thing that is happening is the ventilation that is happening in the nasopharyngeal region, which pushes the air into the eustachian tube. So these are the two subsidiary actions that happen along with our routine action, that is the food that has to go from the mouth to the stomach. So in 1813, Mejendi was the one who said that though this is a process, he said it is in the mechanism is in phases, right? So the swallowing process requires almost 50 pairs of muscles, and it has to have a good neurophysiology. But the uniqueness of this our aerodigestive tract is its position or the importance that it gives to the larynx. So larynx is the one in the center, and we have to develop the airway around. So we'll go to the embryonic situation where 0 to 8 weeks, that is where the larynx tries to develop, and any miscue there will be a problem. So by the end of the 15th week, what happens? The epiglottis to the lower end, that is where the reference point that we make, corresponds to the basic occiput and C3. And 23 to 25 weeks, we have this interlocking of the nasopharynx and larynx, and this is the most important part of the significant maturational horizon. That is what I describe as in this particular development of ADT. So the establishment of this arrangement necessarily will have two separate tubes. Larynx remains high positioned, allowing fetus to swallow. So that intranarial position of the larynx is the one that is what is causing this problem, or that is what is really happening. That is a good thing that is happening. So because of that, the infants are essentially, if not obligatory, nasal breathers. So this portion of the larynx resembles the baseline primate and mammalian pattern. So larynx remains high at that 1.5 to 2 years, it remains high, and about the 7 years, it is in C3, C5 in adults, it is upper border of C4 and the upper border of C7. Now the larynx, tongue and hyoid apparatus, they all descend, and epiglottis and soft palate, they don't even come and meet each other even at the fullest laryngeal elevation. So when this two-tube function loses its importance, then we have another problem to address, that is respiration necessarily has to cease during swallow. So Thiru, at any point of time you can tell me to stop, but for once for once I think swallow has to go and respiration has to cease, right? So the relative low position of the larynx now has created one other problem here, that is the large supraesophageal part and also large supralaryngeal portion. So the supraesophageal part is going to give us a problem of, we are prone for reflux, because here the posterior larynx is not guarded at all, and now this large supralaryngeal portion has to there should be some other importance there. So what is that is going to happen? So that is one thing where the vocal cords produces the sounds, and this can have an intelligible or articulated speech, because the descent of the larynx also liberates the tongue out of the oral cavity and gives the anatomical ability to produce fully articulated speech. So this normal swallow, it is taken for granted always, unless and until you just don't know, or there is a problem there, pain, till such time you don't know whether how difficult it is to have a normal swallow. So it is taken for granted, and the human swallows around 500 to 1000 times a day, and the swallow requires, I think I need some water, right? Nothing but it is a bit of a dry swallow that I am having repeatedly. So swallow requires the action of more than 30 odd muscles there with an well coordinated action, right? Thank you. Right, thanks. Many structures there involved, right, from the bones, cartilages, teeth, spaces, and salivary glands and muscles. When so many structures are involved, so many specialties are also involved in swallow. And the orthodontist, right from the orthodontist who looks after the teeth and the lip closure, to the guy who takes care of the uh, cricopharyngeal region, right? So the effective swallow, how then we really read about swallow? So it was like only now the video fluoroscopic study has started to come, but then how humans really studied swallow, I think some of the pundits here should tell me, but then for my understanding, it is from the lesional studies, from the brain, where there is any lesions there, then they started to have an research on what is happening because of those lesions, and also some electrophysiological aspects where they can give an electrically stimulated area, and also animal models. And that is where they started to really find how important this swallow is all about. So when this video fluoroscopic swallow study started, or where we started to do this, here we can see the amount of the strain that it has, then the lip closure occurs, and then the swallow is initiated. And we do this fluoroscopic study on the lateral aspect as well as the frontal aspect. In the frontal aspect, we will look into the bilaterality or the symmetry that is happening. So you can see on either sides, you can have from the thing, and later part we will also see the piriform fossa just trying to fill it up, right? So this fluoroscopy study, we have 15 components that is going to be discussed, or all these swallow surgeons or swallow physicians, they are going to look into those 15 components. These 15 components are very important. Probably this is what has been represented in that 1 to 1.2 seconds. That is all it happens, and all these things, they happen in synchrony, like a symphony, like it comes and goes, and we don't know what has happened, but the bolus has reached the lower part. So lip closure, tongue elevation, palatal seal, and this represents the first, probably the first phase. We have the 4 phases that we'll discuss, but the first phase is these 3, and then we have the bolus preparation as well as the transportation. And once the initiation of swallow starts, all those 7, 8, 9, 10, 11, all these things come in unison very fast, but here because it has to protect the airway as well as it has to transport the food. And last few segments where the pharyngoesophageal segment starts to open and tongue base retraction comes back, and epiglottic inversion. This epiglottic inversion, as an ENT surgeon, we are all very much sure that we would have seen the epiglottis, and it tries to invert. It is like, again, given in the basic books, not in the books that we see here, the wonderful way how the epiglottis tries to close your airway. That is, the suprahyoid part of the epiglottis and the infrahyoid part behave in a different way in the retroflexion that we have and try to protect. So even the full flexion, the full elevation of your larynx, what happens then is the arytenoids come and get rather pivoted to the tubercle of the epiglottis. So that is where the epiglottis goes in for full retroflexion, and it tries to protect us, and then from there on we have a foot go on either sides of the piriform sinus. So once the pharyngeal closure occurs, and then this pharyngeal closure also occurs in a very fast way, as well as because it pushes the tail of the bolus. So here, when we can just go through the certain aspects of the voluntary control, oral preparatory and oral transport. Involuntary control is the pharyngeal and the esophageal. So I am not going into the real details of these things, because here each and everything will have its own importance, and this will be well appreciated only with a video fluoroscopic study. So, but all these things, when put into a nutshell, will happen within 1 to 1.2 seconds. So we tried our level best to do some animation, and we got this and that is what we can do, because I couldn't get much of animated videos, and video fluoroscopy is not, I'm not having any access of video fluoroscopy in my hospital, so that is where I stand. Oral transport phase is a phase where it is containing, and all these things probably we will skip for a second. Right, the pharyngeal phase. So I will concentrate on the pharyngeal phase, which will be lasting for a second. And what happens here is when the bolus contacts the fascial pillar, it initiates the involuntary trigger. And rather it depends on the texture, taste, aroma, volume, all can alter the bolus. Sometimes a large bolus in a sequential liquid drinking may pass the pillars, as well as it can reach the vallecula before the trigger is initiated. So the tongue base is retracted towards the posterior pharyngeal wall by hyoglossus and styloglossus. So there is a powerful contraction wherein it lifts the larynx as well as anterior hyoid movement, and thereby the larynx or airway is protected and the food passes. So, and this pharyngeal contractions are achieved in a rostrocaudal direction and a wave-like motion from the nasopharynx to the cricopharynx at the rate of 9 to 25 centimeters per second. And this is termed as a pharyngeal stripping wave. As the pharynx elevates, the supraoid muscles and the digastric muscles also contract, directing the hyoid superiorly and anteriorly. So these movements provide airway protection by directing the larynx under the tongue base and inverting the epiglottis. So when the esophageal phase starts, there is a relaxation of the cricopharyngeal muscle, and then once the bolus enters the esophagus, then esophagus has to work there, and in healthy adults, esophageal transit time is 8 to 13 seconds. So here, this is what is happening in 1.2 seconds. So initially it is the loading complex where it happens when the tongue base, as well as there is a movement there with the tongue tip as well as the base initially itself. And you can see the palatal closure there, which is happening at the 0.2 seconds to around the 0.6 seconds, and the bolus head will start to descend, and there is an opening that is happening in the upper esophageal sphincter region, and then the travel bolus takes some more time, that is the tail of the bolus, to reach the upper esophageal sphincter. During this portion, you can note there is a vestibular closure, that is the larynx is protected. So all these things happen, and these are all the timings that is noted there. So we have two things that as a swallow surgeon or swallow physician, that is what is, one is the adductor response, laryngeal adductor response, and the other one is laryngeal cough reflex. All these things will definitely be useful to assess the laryngeal competence. Right. So the neurophysiology, basically how this neurophysiology works here is and it is a dynamic multi-layered process. And what happens here is supratentorial, infratentorial and peripheral nervous system acts. So in a nutshell, we have to just try to understand what is CPG. It is a central pattern generators which is located in the medulla. These receive the signals and they are getting processed, and definitely we have two groups, ventral group and the dorsal group, and the ventral group gets the information, and the dorsal group receives, and then it sends the signals to the motor. So these are the nuclei, these are the neurons, motor neurons involved in CPG, localized in the brainstem activity, and maybe a minute I'll finish. And it includes 5, 7, 12 as well as the 9, 10 and the dorsal motor nucleus. So not all these motor neurons participate equally. So the main motor nuclei involved is 12th nerve and nucleus ambiguus, and these nuclei are critical in swallowing as it provides innervation to the tongue. So to conclude, deglutition is generally the safest when person is sitting with upright position, must be awake and alert, must not talk while eating, as well as always make sure that one mouthful has gone before offering the other one. So with this I conclude my talk, and I wish this particular airway congress that it should go on, and we with the airway and swallow have to go side by side to improve. And anything else? Thank you.
Thank you so much, Dr. Suresh Kumar. Now is professor. I knew him as a Dr. Suresh Kumar. We worked together for some time, and